Hello, good afternoon, dear ladies and gentlemen, dear friends all over the world. It's a big pleasure, joy and honor to welcome you all to our wonderful hearing roundtable. Here in Vienna, it's 3 in the afternoon, and we are all suffering a lot in the medical field about the virus in the last year. So we need some new food for brain to think about something else than the COVID-19 virus. And so our group has decided that we will do a small talk about one of the most important topics right now in audiological field, about the single-sided deafness. And so I want to invite you all to listen to us, and maybe we have some news, good news for you, or some new thoughts or experiences. First of all, I want to introduce our group. So we are the hearing group. So this is a wonderful group recently founded in the year 2008, some years ago. And we are quite some big, huge clinics, and we want to have this as a live event also to include you. So it's not just pure ex tabula telling, so you also should be included into our presentation. So please name yourself if possible, so that we can identify you somehow. All the event is recorded. I hope you can see it later on. Then in the next days, you can see it on our internet, on the hearing. And please do not forget to mute yourself so that we don't hear too many cell phones and other noises. And if you have a question, please raise your hand and we will try to answer as good as we can. So this is the group of hearing. So this was done, this picture, in one of our last meetings before the virus. And you see it's a big bunch of people. Some of them you might know, some are some new ones, but we try to share old and young, but experience. This is the important point. At the moment, we are 31 hearing centers, so big ENT, mostly university departments, and all together we experience over 70,000 cochlear implant patients. So 70,000 cochlear implant patients, and also some thousand other patients wearing any other implantable hearing device on all continents. And our aim is to collaborate on a high scientific level and to share this knowledge with all of you. This is our important emphasis. So we tried in the selection to bring the world-leading experts together. And since 4 years, it's a big honor for me that I'm allowed to steer this committee of people dedicated to all types of hearing implants. The first president for many, many years was Professor Paul van de Heyning. And for me, it's the honor to be the second person now leading this group. It's a very innovative group. If you look into the Medline, many papers come out of these people, of those laboratories and research fellows. It should be comprehensive and educating and educative for all of you. And we want to work together. And this is why we do these meetings now every 3 months. So every quarter, we started already last spring, and we want to continue this for this year, every time with a cool, smart, important topic. You see here some people, you see Paul van de Heyning, you see the colleagues, Kevin Brown from the Chapel Hill group, you see the Daisy Tavora in the middle, and you see the colleagues from Antwerp. So it's purely international from Warsaw. Then you see Luis Lazaleta, you see Ranjit from India, you see Professor Usami from Japan, and Gunesh in former times in Australia, now Switzerland. So we try to make the best out of each topic. Today, we selected the topic of single-sided deafness, of unilateral deafness. We should not forget there are some million people out with unilateral deafness, and for many decades, even centuries, we have not taken care about them. Just since we started the cochlear implantation or the treatment of single-sided deafness, we found out recently in the last 15 years now, 20 years actually, Paul van der Heyning was the first person to start with this. So in the last 15 years where it became more common, we learned how many people are out there with unilateral hearing loss. So this was really surprising. And we learned how to treat them, how to deal with them, and what are the pitfalls and the dangers. So now it's a big honor to introduce Professor Gavilán from the Hospital La Paz in Madrid, University of Madrid, and he will guide and he will present the interactive roundtable. We are long friends. Since many years we don't talk about how long, and I'm very happy that he has done the work to coordinate all this. For me, it was easy just for this introduction, and I'm very thankful now to Professor Gavilán to join after this talk. Have fun and please stay tuned on the topic. We see you later. Thank you very much.
Thank you, Balmi. Hi, everyone. It's a real pleasure to be here with you. And I try to make this an appealing session with discussion as much as we can, and trying to get agreements and try to solve disagreements among us concerning SSD. One of the most important things that we want as a group, the hearing, as Professor Baumgartner mentioned, is to have you participating, to be active members of this roundtable. And to start with your participation, we would like to run a Mentimeter. A Mentimeter is a tool that allows us to have your input concerning what's going on the meeting. If you are able to turn on your cell phones and go to www.menti.com, or just with your cameras take the QR you have on the right-hand side of the slide, you will be able to answer the question with which we want to start this meeting. We want you to go, again, you turn on your cell phones and you go to www.menti.com. You have a code, an 8-digit code, 56922405, where you can enter, or if you go directly to the QR code, you will have a question. You will have to answer just a short word, which is actually, what is the first option, the first name, the first thing that comes to your mind when you face a patient with SSD. So please take your time, go to menti.com and put the first thing that comes to your mind. We need a word, we need an idea, we need anything you think about when you hear SSD, when you bring yourself in front of a patient with a single-sided deafness. There are a lot of different ideas that will come from surgeons, from audiologists, from rehabilitation guys, and all of them will make this cloud word you see on the screen, which is the result of your input right now. So this is the idea for just starting you getting involved, because we don't want this to be just a successive presentations. We want this to be more. We want you to be involved. You have a chat, as Professor Baumgartner mentioned, you have a chat where you can ask your questions. You can raise your hand and ask directly your questions. And right now you have to just put this first word, first idea, first thing that comes to you when you face a patient with single-sided deafness, with SSD. Well, you're watching how this changes. The core word looks to be cochlear implant or CI or cross hearing aid. There are some other words that will be modified according to your input, your answers to this question. But let's move to the round table that we will have. And the first thing I would like to do is to introduce the panelists for this for this round table today. I will be, as Professor Baumgartner mentioned, I will be the moderator of this session, but we have 4 members of the hearing group, expert people on SSD. We will have Dr. Anja Kurz from Würzburg, from Germany. We will have Professor Baumgartner himself, as he was starting this roundtable, from Vienna in Austria. We will have Artur Lorens from Warsaw in Poland. And finally, we will have our ex-director of the hearing group, Professor Paul van den Heyning, as representing Antwerp in Belgium. So without further ado, just let me introduce the first speaker. We will have short presentations, and after this presentation, time for discussion. And the first to speak will be Dr. Anja Kurz. Anja is the technical lead at the Comprehensive Hearing Center of Würzburg. Please, Anja, can you join us? As you all know, Würzburg is runs a large hearing center where they cover all implantable hearing devices from conventional hearing aids to ABIs, and perform up-to-date research on fitting topics, hearing performance with cochlear implants, and also middle ear and bone conduction implants in adults and children, as well as intraoperative monitoring. Anja has over 15 years of work experience in the hearing field and is an active member of the hearing group. Anja will speak about implementing the consensus protocol into routine. Please, Anja.
Thank you, Javier. And hello and good afternoon from Würzburg. I hope that you can all see my presentation right now. Yes? Okay.
Yep.
Good. So I have the pleasure to share our experience with implementing the consensus protocol into clinical routine. So first of all, what is the consensus protocol? During the years 2015, 2016, there were a number of experts, most of them part of the hearing network, that were gathering at conferences and to discuss the clinical heterogeneity of collecting data. So the idea of this consensus was to implement minimal outcome measures. So we are all collecting the same data in the same way, so we can compare our results across clinics, across centers. So what was new to us in Würzburg was that there was a systematic trial of trying cross hearing aids and bone conduction hearing aids before a potential CI surgery. What was also new to us was to use a new setup, which means testing speech and noise in 3 different spatial configurations, which allowed us then to test all the device and to calculate binaural effects, such as the head shadow effect, square summation, spatial release from masking, plus doing a localization task. So we implemented this procedure by mid-2016, and after 2 years in 2018, we said, okay, let's have a look at the data. We changed the clinical routine, so let's see what comes out of it. So after 2 years, we had about 34 participants that underwent this whole procedure. And there were 11 patients that received the cochlear implant and finished their 12-month appointment already. On the other side, there were 16 people that said, well, I don't want to have a CI. I want to do nothing or an alternative treatment. So we were wondering why, what happened. So we had a closer look at the data. So the first thing that we did was to do a group analysis to look at the group demographics. So you are all aware the duration of deafness is the point of discussion. We compared the duration of deafness in both groups, and there was not a big difference between the groups. Then we had a look at the etiology. The etiology was quite diverse in both groups. And the reason why we were really focusing on the etiology was that we did previously a retrospective data analysis of all the SSD recipients that received the CI between 2009 and 2016, so before we started this protocol. Because we wanted to find out how come that we have good performers, how come that we have poor performers. And because of this retrospective data analysis, we could see a correlation between duration of deafness and etiology. Our data showed that when the duration of deafness is longer than 10 years, and the reason for deafening was an inflammatory disease such as measles or mumps, the speech perception outcome with CI is poor. That's what our data said. So back to this clinical implementation. So that was the reason why we also considered etiology in looking at our groups. So in this analysis here, all participants had the potential to be considered for CI surgery. So it was confirmed that the cochlear nerve was intact and functioning, except with one exception. So we were then looking at the group results of the participants that received the cochlear implant. And what we saw that was that there was preoperatively no significant benefit with either the cross device or the bone conduction device. So they received the cochlear implant, and after 6 months and 12 months, we repeated the binaural measurements and the localization setup. And we saw we had nice, significant binaural effects for the head shadow summation, spatial release for masking with the eye. And for localization, we saw a strong decrease in the localization error after 6 months, and even more decrease after 12 months. So this is a nice result for the cochlear implant. So what happened in the other group, the group that did not receive a cochlear implant? So here we saw that in this group, they perceived a subjective binaural benefit, either with the cross or with the bone conduction device. Interestingly enough, we could see that whenever they had to do the localization task, the localization error got worse with the tested device. So this is quite interesting to look at. So what did we learn from all that? Well, we learned that not every SSD candidate is suitable for cochlear implantation. It's an individual decision. So the implementation of the SSD consensus protocol was challenging for us as a group, because we had to reschedule, we had to organize, we had to make sure that the staff is in place, that the equipment is in place. However, our patients were quite grateful that they received such a treatment. And this is the feedback that we're getting, that they really appreciated that so many people talked to them, counseled them from different perspectives. So I would like to show you now how we have implemented this procedure in Würzburg. So this is the clinical SSD pre-testing routine. So there's a minimum of 3 appointments for the SSD candidates. So at the first appointment, it's a medical consultation. And here the patient is receiving a prescription for a cross-hearing aid trial or a bone conduction trial. The reason why the person is receiving a prescription is that we do not fit hearing aids here at the Comprehensive Hearing Center. So we send the people to the local hearing aid acoustician. After about 2 to 3 weeks wearing time, the patient comes back to the clinic. We do the binaural measurements, we do the localization task, and then we hand out again a prescription for the other device, because the idea is to test both devices. And recently we changed again a little thing. Already at the second appointment, we already integrate 1 hour of rehabilitation consultation. We found that the essential part in CI success is auditory training, especially in this group of SSD patients. So already before they get a CI at the second appointment, we tell them, you have to do auditory training, and this is really essential. We want to find out what is the motivation of the patient, what is the environmental setting. And since it's SSD, we, as a CI candidate, or if you're implanted with a CI, you will need external devices, external input. So it's called direct acoustic input. So we need to make sure that, especially when we have the elderly, that we need to make sure that there's somebody in the family who could help in case they cannot set up the streaming directly to device, for example. However, there will be a third appointment, and only at the third appointment, when the patient has tested both the cross device and the bone conduction device, we have measured the binaural effects and the localization. Then we sit down as a team and decide what is the best option. Does the patient proceed with CI surgery, or should we go for an alternative treatment? So all together, we are all sitting in the same boat. It's a group decision. And it also means that there are many, many people that do interact, that exchange information, that work together to offer the best treatment plan for the individual. You can see here on the picture is just a part of the small group. In reality, we are more than over 35 people working here at the Comprehensive Hearing Center. We have many, many professionals, not only the ENT specialist, the ENT surgeon, audiologist, psychologist, speech therapist, so on. Also, we have a lot of staff who is actually organizing all the appointments, the counseling, and so on, who is really doing the back office work. And so I have to say a big thank you to this whole group in supporting this idea in actually finding the best treatment plan for the individual. Thank you.
Thank you, Anja. It's great idea what you had. And the first thing that I would like the people who are attending now this roundtable to know is how much of a group are we as a group? So let me ask you, the members of the panel, Paul, what's the degree of consensus? I mean, do you use the same approach? Is this something that we do as a group? Is this something that they did in Würzburg and no one else does? Can you give us your opinion?
I think there's quite some agreement on this approach. And with the hearing group, a counseling tool has been made, and especially the group from Würzburg has made a lot of effort to make this counseling tool work on single-side deafness. It's now also on the website of Hearing. Maybe Wolfgang can show later the reference to approach that counseling tool. But we discussed a lot about that. We had a kind of World Cafe approach to approaches, and I think there's quite some consensus that is the right way to approach these patients, and that proper selection is a key element, and that this is done with different kinds of approaches, the ENTs, the audiologists, the rehabilitation people, and also the psychologists.
Great. We have a question from the audience. Anja, Dr. La Saleta says that the final decision, according to your presentation, the final decision of going for a CI will depend mainly on patient understanding and motivation?
Not mainly, but it is an important factor. I mean, as I said, from the medical perspective, we need to make sure that the cochlear nerve is intact and that this person has the potential to be a good CI recipient. But on the other side, yes, the motivation is a key factor because, you know, we have this procedure. So we ask them to come back on a regular basis to have the extra testing as we have implemented it here in the protocol. That's on the first side. And in the end, we do not want to produce non-users. So we want to have successful CI recipients. So yes, it is about the motivation. Are you really willing to do auditory training? And this might be really kind of an effort that you have to undertake. It's not just going for a walk. For some it is, but for the majority it might not be.
Great. Artur, what do you think about the reason why, according to what we heard, cochlear implant is the best option? Why so many patients with SSD do nothing?
I think that it is very personal, actually, and different between patient, the reasoning why do something or why don't do something. some patients can adopt very much to in a very extended way, let's say, to the situation that there is no input from one ear, and some of them cannot adopt at all. And for some patients, it's really a lot of effort to cope with the situation when one, especially when one ear is suddenly deaf. The sudden deafness is one of the, let's say, in our clinical perspective, the most straightforward cases to do the cochlear implantation.
Okay, a short question, a short answer for Professor Baumgartner, because we are just moving to the next topic. But before we move to the next topic, what is your experience and patient satisfaction with the different treatment? Baumi, can you tell us just very briefly?
So for the very motivated patient with a short time sudden hearing loss, we see they do very well. So if you have a sudden hearing loss, let's say a year ago or within the last year, and the people are in the mid-ages, so they are doing very well. What we don't want so much are people, let's say, in the 40s, 50s with an unclear anamnesis. So then it's not really clear about the outcome. And in those patients, we rather would go, if they have a normal contralateral ear, to a bone conductive solution, maybe a bone bridge for single-sided deafness.
Great, thank you very much. Let's move to the next speaker, next presentation, next topic to discuss. Will be presented by Professor Baumgartner. You know, he's the professor of ENT at the medical faculty of the Vienna University, as well as the head and neck of the ENT department and senior physician at the Vienna ENT University Hospital. Baumi, are you there?
Yes, I'm there. Yeah.
Okay.
Thank you very much, Javier. So let's start with the counseling tool. You have heard from Dr. Kurz that the single-sided deafness surgery is very good, but it's maybe not perfectly in all patients. And so the point is, when is it good? When you will be successful and when you're unsuccessful. We need to go a little bit back, because the very first person doing that kind of surgery was Professor Paul van der Heyning in Antwerp because of tinnitus. He implanted the first people already in 2000. And everybody of us was a little bit, let's say, unsure if this might be the proper way. But it turned out that just beside tinnitus, it was the correct way and the proper way. But it took some years. Then in the year 2007, Joachim Müller from Würzburg in those days implanted a soldier in the Bundeswehr hospital in Koblenz. And he had a sudden hearing loss and noise trauma from the war exercise in Afghanistan. And this was the real, so known, really hearing loss, single-sided deafness patient. And then I started in Vienna after Joachim's experience. I started in January 2008 in Vienna with adults. And we did quite a number of people, about 50 or so. And in some of them with very good results, in some of them with very poor results, even non-users. And then 2 years later, I was keen enough in the end of 2010 that we implanted the first single-sided children. So I implanted the first single-sided deaf child in autumn 2010, but I need to say it was not a baby. It was a child age 5 or 6, so with a progressive hearing loss and a single-sided deafness in the preschool age. But still then it was not completely clear what should we do to predict. And then it was Professor Hagen's idea from the Würzburg University that we need a tool to find together, because in those days everybody wanted to start with single-sided deafness surgery, but it was not so completely clear what is the proper right way. And so this is the reason for this counseling tool. You see here the QR code, and you can load this QR code directly onto your cell phone, and it leads you to the homepage of the counseling tool. The counseling tool was done under the the leadership more or less from the Würzburg clinic, but the whole hearing group worked together with it. Professor Hagen coordinated, and we have now a systematic literature review and some guidelines how you should do. For example, what we have learned very important is to do the preoperative MRI examination. As we have learned that the anamnesis, especially in adults, is completely wrong. So we have had, for example, audiograms from patients with a natural normal hearing age 10, 20, and then 30 years later they came with unilateral deafness, and it turned out they had no hearing nerve at all in the MRI. And we really see quite a number of patients without a cochlear or vestibular cochlear nerve in the adult age who had not done that for many, many years. So just to mention that. So here you see the QR code, and you can go into this homepage if you want to start, if you have patients, how to manage and how to do it. So you click and then you go in, and we have several solutions. So we have in single-sided deafness, of course, no treatment. That might be if you have a surgical contraindication, contralateral routing of signals in hearing aids, as we had for decades. But I need to say, all my patients are very, very unhappy with this. Sometimes I have really discussions with our hearing aid acoustics because they love it very much. On my opinion, if I see what they charge for the system, it's clear why they love it. And then we see the bone conduction devices for people where it's not clear about the hearing nerve, with good contralateral hearing up to 10, maybe 15 dB on the healthy ear, and the cochlear implant, especially, in my opinion, very good for the kids. We have in the meantime very, very good results in preschool children, even smaller kids and babies. And now we go to the homepage. We have investigated over, in the meantime, more than 180 papers, and all our surgical and practical audiological experience of all the 31 hearing centers and experience with those patients. And here you see now we are in the homepage. So you see restoring the deaf ear, binaural hearing, how it works, how important the binaural hearing is with the squelch effect, with the head shadow effect, with the summation effect, of course, with the spatial hearing, the directional hearing. You see, especially for the kids, and this is tremendous, and we will see this certainly in the next years. We have at the moment all the studies ongoing in school children. Those studies are not finished and not published, but we see it and we feel it, and we see it from the first data that they really do much, much better in school, those kids. Of course, we know since Paul van der Heyning the tinnitus reduction, which is definitely true. There are some drawbacks, but I do not consider them as major. So they're really just small negative moments. For example, you need with the cochlear implant, of course, a lifetime follow-up with a medical doctor. But to be honest, in our Western cultures, all our patients need follow-up for the end of days with diabetes, with blood pressure, whatever. We see the MRI artifacts. What we need, and what was often underestimated, is the need for rehabilitation, especially people in the more adult age with a longer time period. They need rehabilitation. It's not an on-off procedure. So this is in the cochlear implant very, very, very important to say this. And here on the homepage, this helps you see, if you open the homepage, you can go to the paper. So we have 180 papers, even more in the meantime. You click on the paper, you see the paper, you see the author, you can read it. And so you can find a way in your department, no matter if you're a lot of people, a huge department, a big university, or if you're just a lone ranger out in the world, so that you have a scientific background to work with single-sided deafness patients. So we think that this tool is very, very useful, and there is a lot of brain work in it. Please use the QR code, go to our homepage and use the counseling tool. This certainly will improve the outcome of your patients, and it will also improve your life as surgeon or audiological person. Thank you very much.
Thank you, Baumi. We have a question You already mentioned that Professor Hagen from Duisburg is one of the fathers of this project, of this tool, of this counseling tool. He wants to ask you, maybe to you, Baumi, or to also to Anja and Artur and Paul, can you estimate the rate of failures in SSD after cochlear implant? Anja.
Well, the rate of failures in terms of technical problems, I would say nearly zero, I would say.
No, I mean, I think he's asking about failures in the sense, not technical, but not successful results after cochlear implant.
Well, I would say it became better now that we have the systematic procedure. So we saw when we did the first data analysis with all the patients that got implanted starting from 2009 to 16, we followed up on them, and we even sent them questionnaires to ask, are you still using your CI? And the outcome was that they reported that about 80% of them said we are still using the CI. But of course, we lost contact to some of them. That's why we sent them a questionnaire or called them up. So we cannot really control it. If the patient does not come back to the clinic, we're not sure. But as I said, from that follow-up task at that time, it was 80% are still users.
You have the same opinion, Paul?
Well, the failures we had, but I come back later in the presentation, are those patients with a major depression. If patients are presented with a loud tinnitus and a single-side deafness, you need to be aware, but I will come back in my lecture on that. Our failures were that, and we had also one patient whose primary complaint was hyperacusis. Mm-hmm. And also that patient at the end could not stand the cochlear implant.
Okay, for the online, go ahead.
Yeah, it was the primary complaint of the patient. She came because she had a severe sensory neural hearing loss, but her primary complaint was hyperacusis. And this is a central phenomenon, and it did not improve. We hoped that it would improve, but at the end, after 1 year of rehabilitation, whatever, she decided not to wear it anymore.
Great. For the online managers, can you please put the QR code again? Some participants want to check it. And meanwhile, Artur, the surgeons, and Baumi mentioned that, we don't have a very good feeling concerning Cross. Can you give us a different opinion, or you are also not very satisfied with the results of Cross hearing aids?
From the clinical experience, I can confirm that patients are really struggle with ordinary Cross, and the number of non-users is pretty high. So usually it looks better in terms of bone conduction devices, but just not referring to the results, but having a feeling of discussion with patients, I can say that usually if they are happy, they are not so happy like some patients with cochlear implants. And the biggest difference we can observe is for patients after cochlear implantation.
Baumi, we have right now a new device that can also be used. It's a bone conduction device, but it's not an implantable device. Do you have an idea about how this can impact on the solutions for single-sided deafness?
Yes, thank you. So I want to mention the name. It's the Adhere, and we have already the Adhere test trials already. I think it's already finished at this particular moment, but it's not written down. And we have, surprisingly, quite a number of patients who are doing very well. I think the most important thing is that the contralateral healthy ear is really healthy. So it need to be really at maximum 10 dB ear and not worse than that. If you have elderly people, let's say the contralateral ear is 20 dB at 1 kilohertz or worse, then the adhere does not work at all. But the adhere definitely has surprisingly SSD emphasis, definitely. And what we see also in children, we try the adhere maybe even in preparation to another surgery. So if we have arthritic children and we prepare a bone bridge surgery, which takes, because we need the CT scan, we need some other exams, this can easily take half a year. Then in this half a year, the adhere is definitely a solution, and we must not forget it. It's new, and in particular cases, it really works.
Okay, we have a good question here from the audience, from Ranjit. What do you think about the social stigma of wearing a CI as a reason against using CI? Anja.
Social stigma. Well, I mean, it depends on the person. I mean, there are some people that come in and say, well, I want to hear, I'm losing all the localization, the whole spatial impression. So I really suffer. And therefore, the idea to receive a CI, to have, you know, this input rehabilitated is, you know, this is what you get from it. So I think it's worth doing it. There are some people that I also have in mind that already have been deaf for quite a while, and they have now anticipated, you know, this attitude of I am hearing impaired, and everybody can see that, and that's okay. So it really depends on how they feel about this stigma of not hearing, of accepting, okay, I'm deaf and that's how it is, I cannot do anything. Or the other side is I'm deaf, but I do have help, and I'm wearing a CI, and everybody can see that, and I'm proud that I'm hearing again. It really depends on the person, I would say.
Good, good, good. Paul, do you think the counseling tool may be a tool to reduce the number of non-users? I mean, going there, do you think that we can reduce the number of people that after one of these solutions will not be users of the solution?
Yeah, I'm convinced of that. The counseling tool gives a very broad view on the different indications and also the caveats that you have to avoid in opting and choosing for a patient. I want to say two elements also. When you counsel the patient, when they're choosing different options, patients also need the time to make their choice. It's not the patient who's coming at your consultation with an acquired single-side deafness that you should force him to take a decision in 1 week or 2 weeks. Now, this is a process of 3 to 6 months at least, and you have to give the patient the time to do so. And if you do so and you give a proper normal expectation, then you will have a lot of more people that will continue using. For instance, the bone conduction devices, we did an analysis 10 years afterwards, and the majority of patients were still using it, but only in very, very particular conditions. And if you tell that to these patients, then you make these happy patients. You have to avoid to have unrealistic expectations.
Great. Well, I think it's clear that the most important task we have as doctors is to get happy patients, and this is mainly by using the device. Baumi, you want to say something?
Yeah, yes, about this very important question of social stigma. So I personally experienced a big change in this topic in the last 13 years. When we started in 2008, it was really a topic for the patients having this audio processor on. And now with the new generations of these small audio processors, it's not even a stigma anymore. It's a sexy tool, it's fancy, it's smart, and it looks much better than those lousy iPhone headphones, really. So, and especially now with these different colors, we have patients who purchased from the manufacturer a lot of cover plates just to show the audience their personal attitude. So there was a big change in the last decade.
Great. Well, Paul, we have to move to next topic because time is what we have. We have one hour and a half, and we cannot go further than that. But before proceeding with the next speaker, that will be Artur Lorens, I want you, the participants, to all please turn on your cameras, because we are going to take a group photo. Don't worry, this photo is not going to be published, so you can be safe, but we just want to have a nice view of all of you during this round table. So please turn on your your mobile, I mean your camera on your laptop or cell phone or the device you're using for this round table, and I will make a countdown from 5, 4, 3, 2, 1. Smile, and we have the picture. And thank you very much. You can go back to your previous situation. You can take off your cameras, and we will move to the next presentation and discussion, subsequent discussion. The speaker will be Artur Lorens. Can you please, the online managers, bring Artur with us? Artur Lorens is the professor and head of the Department of Auditory Implant and Perception of World Hearing Center at the Institute of Physiology and Pathology of Hearing in Warsaw. Artur has extensive scientific experience in the field of auditory implants, psychoacoustics, and auditory perception modeling. He's a member of multiple scientific societies and has been in charge of the Hearing Treat Marie Curie EU project during the years 2006 to 2010, and has received the first award from the Minister of Health and Social Welfare for outstanding achievements in healthcare. Artur is a member of the hearing group since the beginning of this group, and he will deal with cochlear implant in prelingual SSD patients. Artur.
Thank you, Javier, for this kind introduction. The reason of talking about the prelingual patients is because this can be also the reason for being unuser or unhappy patients. And the theoretical background for that is something which we call actually the syndrome, which could be connected with abnormal aural preference. So when unilateral deafness occurs in early development, we know from the literature that there is a situation that the hearing ear become overrepresented in terms of neural representation. So the congenital single-side deafness promotes an abnormal aural preference, and after implantation, the representation of this normal hearing ear is just stronger, more extensive, represented in the auditory system, comparing to the CI ear, which we can consider as a weaker one. There are a lot of actually evidences from the animal studies, but also from the human studies too. So the early onset of unilateral hearing puts the deaf ear with CI into a significant disadvantage for competition for cortical resources. So the responses for the deaf ear were not completely eliminated in the brain. But this is something which is really worth to be actually discussed, because if the responses for the deaf ear are not completely eliminated, the question, the clinical relevant question is if this weaker representation can be still actually used for the benefit. And what I now want to share with you in the next couple of minutes is actually our results in a large material. We analyze now the material of 293 SSD patients and 263 patients with so-called asymmetric hearing loss. From this large material, we selected 7 patients with SSD and 6 with asymmetric hearing loss. We published already 3 papers. First paper actually concentrate of comparing patients with tinnitus and non-tinnitus, we found that there is no differences between the performance in these 2 groups. So we can safely implant patients, of course, without tinnitus too. The effects like squelch effect, redundancy in quiet and noise, and head shadow, which is on this first slides in the gray bars, there is the differences between CI on and CI off conditions. So we can see that there is actually significant difference. The biggest one, of course, for the head shadow, 20% percentage points in monosyllabic tests, and this is visible, actually, this benefit for all effects. But if we just contrast these results with the results of a subgroup, of a very small subgroup so far, with the prelingual onset, prelingual adults with SSD and asymmetric hearing loss, we can see that the only head shadow seems to be on a verge of significant, it seems to be quite similar, actually, in size, 15 percentage point to what we see in a postlingual patients. So it is still a hope, but the more research is needed to show in an objective way the benefit in terms of an effects. In terms of a localization, we see a clear effect. So we can say that the prelingual adults, so with the smaller, weaker input from the implanted side, can actually contribute to a better localization. But we cannot see any effects in terms of a questionnaire. We choose this questionnaire before the consensus paper, and maybe it's not the optimal one to see the effects. The effect is visible in the postlingual patients, however, in the AFAB questionnaire, but it is not visible in the prelingual subgroup. So just to conclude, or just to actually raise some potential question for discussion, I prepare a list of 6 points. Basically, can the weaker ear produce the binaural benefit? This seems to be the case from our preliminary results in postlingual patients. Does the potential for reversing the preference for the stronger ear exist? Maybe some rehabilitation treatment should be develop, and of course the duration of CI use can probably choose the results, so maybe longer duration is needed. Can we think about the special paradigms for training? Timing of treatment may be very important, and this is going into direction of small kids. And of course, to what extent can the early implantation, this kid pediatric question, provide sufficient symmetric and produce normal aural preference, avoiding asymmetric aural preference. So this is actually a lot of potential points for further research. Thank you so much.
Thank you very much, Artur. It's been a very interesting presentation, and with a lot of questions at the end. I will just pick up one of them to start the discussion. Timing. What's the best timing for single-sided deafness in prelingual patients to put a cochlear implant? Paul.
Well, this has to be in this very sensitive period of language development. So the earlier you do it, the better. Up to now, there's no clear answer. What is then the ultimate date? It's clear that patients with an asymmetric hearing loss, that you have somewhat more time. There are also children that have some progression in their sensorineural hearing loss, single-sided, in case of cytomegalovirus and so on. But those that have really congenital sensorineural deafness, I think you should do it before the age of 2.
You agree, Anja?
Well, we had a couple of children that received the cochlear implant at diverse stages of age, and we found that it's quite the outcome is quite diverse. So the rule at the moment is to implant as early as possible. 2 years is really, really early. I mean, the time when we see them, they are usually around 3 years old, and they always have to undergo a hearing aid trial before. So, and this one has to be tried before. So I'm not sure if we can identify them as early as possible. Of course we can, but we need to prove that they have tried hearing aids before. And as soon as the parents report, okay, we don't see any benefit, then the direction is clear. But we do have the experience that children at around 7 or even teenagers receive the cochlear implant. And here the outcome is quite diverse. So I agree, as early as possible. Yeah.
Artur, you want to say something?
I think that it could be also that the sensitive period can be different for different actually abilities, like sensitivity for ILD or sensitivity for ITD. For example, if we can see the head shadow effect even in adults with prelingual onset or localization, basically probably due to the ILD sensitivity, maybe this is not so critical for this particular ability. So my point is that, of course, it would be better to implant as soon as possible, but we still don't know if some of the binaural ability can be actually presented, even if this surgery is later, just we miss the sensitive period.
So this means that the duration of deafness will play a role in your counseling? Baumi, will you consider that?
Yes, definitely. But maybe I want to hang up to the last question. Of course, our youngest is 2 years old, but we need to consider that the etiology in the single-sided deafness is extremely different. For example, we cannot assume, if we have single-sided deafness kids, that the contralateral ear will stay well forever. We have syndromic children, for example, Waardenburg syndrome, where we know that in 10, 15 years, at this particular moment, still healthy, so-called healthy ear, might very probably become poor. And so at the moment, we're still learning this. So this is just I wanted to mention. Yes, in the adults, the etiology is a big topic. As the Würzburg group, independent from them in our own data, we have, without talking to each other, also the 10 years postlingual cutoff point. And what we unfortunately learned is that the majority of anamnesis in those patients is completely wrong. It's more or less bullshit. So they tell you what they were told themselves as kids from parents, grandparents, something, and the reality is completely different. So you really can assume, if patients tell you, if they're 40, 50 years old, they are deaf since 10, 15 years, that they are most probably congenitally deaf. They were simply not known in this particular moment, and this gives you a lot of potential of failure. And this is why the counseling tool is important. But for us, the duration is an important thing. And we definitely will not implant a single-sided deafness person who has a duration longer than 20 years, although this is already to discuss.
Okay, so let me bring you one question from the audience. The question says that if timing is unclear, apart from having an intact cochlear nerve, a positive psychological analysis and motivation, can you say about any other certain prognostic factor for cochlear implantation in SSD prelingual patients?
Yes, the MRI should be good. So he should not have dementia or multiple sclerosis or some of these general neurological diseases. They are harmful. But if there is no neurological disease, that's it. Yes.
Something else, Paul?
Yeah, the environment. You have to be sure that the environment is very stimulating for the rehabilitation process.
Something else we can tell them?
I think that, again, we should point to the rehabilitation process. So this motivation is not only just to passively try the CI, but we confirm the all other experience that the rehabilitation training is a key factor for success.
And I think
Good.
also,
And yes, go ahead, Anja.
I think also one point is maybe we're a bit pessimistic and when we are counseling our patients, but we are trying to set the expectations right. And it's better for us to counsel very, very low, and then we are much happier afterwards if we have success. And one thing I have to say with the long duration of deafness, we do have patients that received the CI even when there was deafness confirmed after 40 or 50 years. And even if those patients do not have speech perception on that ear, they do have a perception, a spatial perception of the room. And that's what I can test with the localization setup. So in the end, also those patients are happy that they have received the CI, even if they do not understand speech. That's something we should keep in mind, apart from the motivation, cochlear nerve intact, and so on.
Okay, so after all this, Paul, go ahead.
Yeah, it shows that the neonatal hearing screening should be done in both sides because we now have this possibility for cochlear implantation.
Yeah, right, absolutely.
Good, and just to give the audience an idea, I know this question is a bit weird, but to give the audience an idea, what's the percentage of patients you will say in this situation we're dealing now with that will be at the end implanted with a CI? It's 10%, 20%, 90%?
It's difficult to answer because those patients who come to our university are already pre-selected. So those are not the ordinary people. So they are sent more or less to us already prior to our surgery. So we have quite a high number. So I would say we implant about 60% of the counseled patients.
But imagine for those in the audience who are not the place where they send the patient for implant and they see patients with prelingual patient with SSD, the percentage will be smaller than 60%, I understand.
Yes, definitely, yeah. Right.
Like what, Paul?
Yeah, well, the aspect of the stigma you raised, which is not such important for adults, but we found out that it is quite important for mothers for their children with single-side deafness. Then the implant or the visibility of the implant is a burden as a stigma. And I think from the moment that also fully implantable will be available, that this will change our attitude.
Right. But to answer,
great.
To answer,
yes. Last comment.
25%, I would say. I would say from the first question you raised, from outside the department, 25% of those patients you can implant.
Okay, great. So for those who are attending this roundtable, the experts will implant 1 out of 4 patients with this situation. Well, let's move to the last presentation. We'll have our vice chairman, Paul van de Heyning, which is the professor of the Department of Otorhinolaryngology and Head and Neck Surgery at the Antwerp University Hospital. Could you please, the online managers, put Paul here with us while I finish the introduction. Paul has published a huge number of articles and supervised more than 65 PhD projects. His research is focused mainly on inner ear pathology and cochlear implantation, and he has developed the application of cochlear implants in single-sided deafness and tinnitus. And this is the topic that he will deal in the next minutes to finish our presentations and to end up with the last discussion of this roundtable. Please, Paul.
Yeah, thank you, Javier. Apart from acquiring the hearing loss in single-side deafness, a lot of patients will develop also tinnitus. It is estimated that about 40% of the postlingual single-side deaf patients will suffer from a disturbing amount or level of tinnitus. So why is this? Why is this the reason? Well, when you lose your hearing, then you get a kind of inappropriate brain plasticity. It's the same as when you lose an arm and you get phantom pain. This is a phantom type of tinnitus. So your central auditory system will change, and this will lead in the hearing line, in the lemniscal line, to the tinnitus, also to forms of hyperacusis. But also there is a network starting from your auditory input that influences your limbic system, and the disturbance will lead to this distress, annoyance, affection of mood. Before going further and say, well, if we reverse this, if we give back hearing, for instance, with a cochlear implant, then maybe we can wind down or reverse this inappropriate brain plasticity and wind down the tinnitus. But we have to be aware that hearing loss is just one of the reasons. It's an important reason, but one of the reasons of tinnitus. When there's something on the wiring of your central nervous system with neurological disorders, or a specific input from a temporomandibular joint dysfunction or cervical pathology, like in whiplash, then also tinnitus can arise. And most importantly, it are psychogenic and psychiatric reasons that may influence it and give a top-down effect, like in depression or in burnout. And this can be sufficient to yield a huge amount of tinnitus, or it can increase the pre-existing tinnitus to the hearing loss. So it means, what is the consequence? The consequence is that if you restore hearing with cochlear implantation, you will improve the tinnitus, but only to that amount that it is the result from the hearing loss. Cochlear implantation is treating hearing loss and not tinnitus per se. It is even only if there is a link. And then we have to be aware that we will be faced with two types of patients. With patients with acquired single-side deafness, and that develop this tinnitus, but whose primary complaint is the tinnitus. The tinnitus is the most bothersome. And other patients are coming to the consultation, and their primary complaint is the hearing loss. So we will deal a little bit separately by both of these type of patients. First, those with the tinnitus on the foreground as a complaint. And then the selection criteria have to be, well, per se that the patient has very loud tinnitus. If they have realistic expectations, that means a decrease of tinnitus, not just abolishment of the tinnitus. If the MRI is okay and you can do a full implantation, then this is probably a very good candidate on the condition that you're sure that the tinnitus is the result from the hearing loss and that the patient has no major depression. All the cases I've seen, and also some of our patients that after did not use their cochlear implant, were patients that had a major depression. The patients we had were patients sent to their psychiatrist asking to do it, but it's clear CI is not a treatment for major depression that we knew, but it's something that's very important, and all your patients have to be seen by your clinical psychologist. When you do this, then you get this type of results. At the left panel, you see the loudness in a visual analog scale, 0, no tinnitus, and 10, very loud tinnitus. And the patients in our group had very loud tinnitus, 8 on 10 before the surgery. And then after 1 month and treatments of rehabilitation, of fitting, the tinnitus went down to 1/3 to 1/4 of its initial value. And our first patient that we operated was 2003, so more than 15 years ago. And all these patients kept their effect all this time. We had no recurrences of it Only if the patient switch off the cochlear implant, the tinnitus comes back. So they have only this improvement by activating the cochlear implant. At the right panel, you see the tinnitus questionnaire. This assesses the annoyance, the distress of the patient. And there we see that we get to a half of the initial distress, initial annoyance of the cochlear implant. And now we see the effects in the category of patients coming for the hearing loss. At the right side, this is a group result of patients with bilateral deafness who got a single cochlear implant. And it's well known for a long time that more than 70% or 60–70% of patients have an improvement of their tinnitus. When we look at our category of patients with single side deafness, also there we see that up to 85% have a very important improvement of their tinnitus, but still some 10% is unaltered or some aggravation. It is often due to the other reasons that prevail in provoking the cochlear implantation. So I come to a kind of conclusion with these tinnitus. Of course, CI can improve hearing capabilities, better speech and noise understanding, better directional hearing, better quality of life. But as to the tinnitus will be a very good indication. You have patients that will wear the cochlear implant every day from the morning that they open their eyes until they go to sleep, on condition that you have to rule out the major depression and that you take care, together with the implant, also on the approaches on tinnitus retraining therapy and cognitive behavioral therapy. It's not an alternative, it goes hand in hand. And so careful selection and proper counseling, again, is a very important element.
Thank you, Paul. Can we say that SSD plus tinnitus minus major depression is equal to CI?
Yeah, this is absolutely a very, very good indication. Patient will be extremely grateful that you did this. And in Belgium, we have problems in reimbursement in single-side deafness. This is the indications that our patients are really willing to pay for themselves also for cochlear implantation.
You agree, Bomi? Unmute your mic.
Over 20 years ago, Paul told me this, and I did read his papers, and I visited him in Antwerp to see those tinnitus patients, and it was really overwhelming. And we have actually similar data. So we started a bit later with the tinnitus patients, and we still see tinnitus as an alternative indication actually for cochlear implant in single-sided deafness. Actually, the cochlear implant has two indications. Indication number one is tinnitus. Tinnitus alone, in my opinion, is enough indication. And of course, if you restore the hearing ability, then it's an additional plus. So I see we have two indications for this.
Artur.
Yeah, definitely. I think that I just want to refer to this first paper published from our center. Professor Skarżyński actually decided to compare this tinnitus and non-tinnitus group, because the fear was that the binaural effects are sort of an additional benefit comparing to the tinnitus. It's not so important for the patient as the tinnitus is released. And this our first paper was sort of a fundamental for us, because we showing the great binaural effects and very happy patients without the tinnitus. We actually could extend this SSD program in our center, and that's why the number of CI patients, SSD CI patients, increase in our center.
Good. I have a question for you, Anja. It's a question from Luis La Saleta, and it's a tricky question. You mentioned before about expectations. So what will you consider realistic expectations when explaining a patient with SSD about cochlear implant? What does the average patient get after SSD with a cochlear implant?
Well, the way how we counsel is not in a way of telling them numbers. So the way how we do it is to say, you are an individual, everybody is an individual, and the reason for deafening is with everybody different. So what we really push forward is that you need to do training. This is about auditory training, and you need to do training. We say twice a day, 15 minutes via direct input. There is a handy app. You can even start training right now just to get familiar with that. And I mean, here in our clinic, we hand out prescriptions for speech therapy. So that's the first option, to really start training right away. Of course, there are, there is the ambulant rehabilitation program. And then, of course, there's stationary rehabilitation, where you really go to a center for 4 to 6 weeks and just do nothing else than hearing training, where this is not really covered by the insurance here, at least in the area where we are working in. So the first thing is always to hand out the prescription for speech training and to not tell them any numbers. It's like we're telling them, you have to do work and then you will be successful.
Yes, but this is very theoretical. I want something more practical for those who are listening now, hearing you. How do they approach? What can they offer the patient with SSD after a cochlear implant? What will change? What will they get?
They will for sure get a perception of the room. So the spatial perception, this will become better. So this is something that we can counsel and we can tell everybody. We do not give any guarantee for speech perception, how good it will be and how fast you really achieve a high score. But you will get back the perception of a room. So the localization will become better. That's for sure.
Good. Paul?
Yeah, some of my patients with the tinnitus going down, they told me we got our life back.
Good.
And what we do in all our patients is to bring them into contact with a patient that had the intervention. And then they go home. We are not with them. We give 1 or 2 people that they can contact and have a chat with, or often they are invited for a cup of coffee and have a talk, how these patients who went through it experienced the benefit or what it was, a cochlear implant. I have to say, after these talks with patients that had the intervention, we did not need to convince them anymore.
Okay, I have one more question for you, Paul, coming from the audience. Is there any specific rehabilitation protocol that helps with the management of tinnitus in SSD, something which is different to other CI users without tinnitus?
First of all, there is the rehabilitation of the cochlear implant in a classical way, and then we add to that, if necessary, the psychoeducation of tinnitus retraining therapy, and some patients have also benefit that you feed also some background noises in the same way that you will treat other tinnitus patients.
Okay, one more. Yes, Bomi, go ahead.
Back to your question you raised, some of our patients said with the bilateral hearing in single-sided deafness, they hear the world in colors. So the world is back again. And this, I think, this is very true. And what we can give nearly all the patients, more or less quite soon in the first month, is the directional hearing again. That makes them much safer in the traffic and in the everyday life. What I want to mention, we have not mentioned at the moment, I really not believe, I don't believe it. I'm sure, and I think we can prove it in the meantime, that especially in single-sided deafness, the deep insertion and the correct pitch matching is very, very important. So I think that short electrodes have really no use in single-sided deafness.
And in other situations?
No, I mean, in those situations where you can have it surgically done, but if you, of course, but generally in single-sided deafness, what we see in the programming is the pitch matching according to the cochlear anatomy much more important than usual.
Okay, let me take one of the examples I see very often. We create SSD quite often by doing acoustic tumor removal through a translab approach. Imagine we couldn't preserve the cochlear nerve, so there's no cochlear nerve. The patient has serious tinnitus, a very serious situation. Do you think that we may think about ABI as an option for these situations, or I'm going too far?
No, we have not done it, but we would do certainly. Yes, I think it is an option, right?
Paul.
Yeah, we did one patient. It was not an acoustic neuroma patient. It was a patient who had an obliterated cochlea, and we could not do a full insertion. In that patient, we did an ABI with very good results on reduction of tinnitus, and the patient also got quite reasonable speech understanding. We published that last year in otology and neurotology.
Yes, Anja.
Well, I have an ABI patient, SSD ABI patient, and we are just in the process of, getting the programming right. And with this patient, I'm especially curious to look at the localization results. So whenever I see this patient, I ask the patient to do the localization test setup. But to be honest, due to the occurrence of Corona, this all stopped. However, but this is a really important and interesting case, to have ABI in SSD patients. So that's something we should really have a look at in the future.
You agree, Artur?
We actually have patients with ABI with asymmetric hearing loss and having hearing aid on the other side. And we also discovered the localization ability and even some of the binaural effects present in this patient. So I am also quite positive that not only the tinnitus can be improved in terms of a reduction of the tinnitus experience, but also some of the binaural effects can be also restored using the ABI.
Okay, well, time is almost over. I don't know if you want to add something, each one of you of the panelists, or everything has been said. If there's nothing else to add. Yes, Paul, please.
Yeah, well, when we started doing it, it's 2002, 2005, then there was a lot of opposition and disbelief that cochlear implantation was an indication for single-side deafness. I think this is now far behind us, and cochlear implantation is definitely a very good indication with the proper selection, like every therapy, for patients with single-side deafness.
Well, great. Thank you very much. Well, after this roundtable, what it's clear to me is that SSD is an exciting and challenging topic in the field of hearing loss rehabilitation. Of course, as you had the chance to see during this almost 1.5 hours, the final decision, it's like for any other situation in medicine, it's a personal decision, depends on patients' preferences, but our role as experts on hearing in counseling and providing adequate and complete information is absolutely crucial, in my opinion. We had the chance to learn about the consensus protocol supported by this group of experts in hearing rehabilitation, the Hearing Group. And I know that most consensus meetings end up with the final consensus that there is no consensus. But in this occasion, I think the proposal by Anja Kurz sounds to me like a very good approach to the problem of SSD. You also had the chance to learn more about the hearing counseling tool, another of the sons of this hearing group. This counseling tool is available to everyone on our webpage. If you go to www.hearing.com, you will have this counseling tool. You can check and please visit the webpage and let us know your opinion about the tool. The issue of cochlear implants in SSD in children is a real challenge, which is still unresolved. But I'm sure that a lot of discussion will take place in the near future about this topic, and more light will be shed on the problem. And finally, the impact of tinnitus in the management of patients with SSD cannot be overlooked and should be included routinely in the management decision tree. In my opinion, tinnitus may help pushing the scale in patients with single-sided deafness by adding another reason to choose CI as the best option to manage the problem, as was emphasized by the four panelists in this roundtable. I hope you enjoyed this roundtable, and I would like to encourage you, all of you, to share with us your doubts, your projects, your research, your ideas, and I'm sure that you will always find support from some or all of the hearing group members. Well, before closing, I would like to thank the speakers for their great job. They did a wonderful job. It's not easy to be able to transmit information when you are in front of a camera speaking to no one. But I know that they were able to transmit their knowledge, and thank you for sharing your experience with us. I would like to thank the participants for being there and give meaning to this online event and to everything we do. If it was not for you, we will not have a reason to be here. And of course, I would like to thank very much the technical staff, the online managers, for making this a smooth, easy, and attractive experience. We had no dogs barking, no naked people coming behind us in the middle of the show, and that's something that we really appreciate. I wish we could meet in person very soon, but meanwhile, we'll have a series of quarterly roundtables, as was mentioned by Professor Baumgartner at the beginning of this roundtable. We will have this, the first one, which is the spring one. Actually, we're not yet in spring. It's going to be 3 days from now, but this is the spring meeting. We will have a summer, fall, and winter roundtables like this one, and the topics to be discussed in each one of them will be announced in advance, and you will have previous information, and we will love to see you all here on 24th of June for the next roundtable from the hearing group. Thank you very much for being there, and keep safe.